Hello and welcome. I'm Dr. Gwen Cohen-Brown, speaking to you from the Dental Hygiene Clinic of New York City College of Technology. Did you know the American Cancer Society estimates there will be over 60,000 new cases of oral and oropharyngeal cancer in 2026, or that 1 in 3 adults in the U.S. will have a medical visit this year but not see a dentist? Every medical provider can impact positively on their patient's health by performing an intraoral, extraoral exam completely and effectively, all in under 2 minutes. We are not only looking for oral cancer, but for any abnormalities which may present in the oral cavity. This basic exam is an essential tool in assessing your patient's oral health, and they can detect some early changes in their systemic health as well. The etiology of oral cancer has changed greatly over the past decades, predominantly due to the increase of HPV infections, although the process of performing the exam remains the same. You must have excellent visualization of the oral and perioral tissues with a good light source, preferably an LED light, as well as the ability to perform bimanual palpation. Let's watch the video and see how this is done. Did you know that oral cancer is underdiagnosed? Every medical provider can impact positively on their patient's health by performing a simple exam. In order to do a proper head and neck exam, one of the things that's the most important is to remember to do it in the same sequence every single time so that you don't leave out a step and forget to examine a certain part of the area. When I start, I tend to start from behind the patient, and I'm going to explore the occipital nodes. Occasionally, you want to have the patient put their head back a little bit so that the skin isn't so tight and you can actually get under there to feel where the nodes are. If you have an enlargement here in this area, one of the things you certainly can think about are things like mononucleosis. Following that, I'm going to take the patient's head and gently turn it like this so that I'm releasing the sternocleidomastoid muscle, and now I can get my hands around it. The most superior part of the anterior cervical chain is right here, and when you have anything draining intraorally, you're going to start getting some enlargements of these lymph nodes in this area. Now, you can look at the posterior lymph node when it's released like this as well, but it's often easier to do it on the patient on the other side. After you do that, you turn the patient's hip around and you do exactly the same thing like here, where I'm releasing the muscle on the left side and then examining the posterior part of the cervical chain over on this side. After this, I'm going to have the patient swallow, make sure everything is mobile, and then I go to the posterior part of the angle of the mandible, work my fingers down towards the apices of the front of the mandible, somewhat underneath in here as well, just to make sure things are mobile, and I'm going to wind up at the joint. Please open. There are 2 ways at least of taking care of the assessment of the joint. I prefer to have my fingers behind the patient's opening joint, and that way I can feel what happens very clearly when the patient is opening and closing. Open and close, please. The other way of assessment, you can put your hands here, but what you're really feeling is changes in the muscle, not so much on the joint itself. Following this, I'm going to go around the patient and do a similar assessment from the front. Again, I'm going to ask the patient to open and close, and one of the things you look for is deviation, any crepitus, which is what the terminology is for crunchy sounds that you hear in the joint. And essentially, if you do not have pain, there's no reason, even if you have crunching, to go in and have anything done to change your occlusion, to change your bite. Even a night guard might not be necessary. Following that, I'm going to go back down on the mandible, have the patient bite down really hard, feel the masseter muscle, go forward, and then we're going to start the intraoral component of the intraoral exam. You want to make sure you're doing everything exactly the same way every single time so you don't forget anything. And what we have here is the lips. On the bottom of the lip, inside the cheeks, what you have are minor salivary gland lobules, and you have around 700 to 1,000 minor salivary gland lobules, and any of them can be obstructed or broken or collapsed, so it is not an uncommon thing to see at all. Bite down, please. You can look at the teeth, make sure everything looks healthy, that there's nothing obvious decay, that the patient isn't missing any teeth. And then you're going to put your fingers in the vestibule and make sure everything feels smooth as well. Open, please. Following that, you're going to palpate the floor of the mouth. And the way you palpate the floor of the mouth is called bimanual palpation, because you're pushing up against something. If you were not pushing up against your fingers, you would not have a very good sense of what you're feeling because you're pushing through, and it's all soft tissue down here. Have the patient open, tilt your head up a little bit and say, ah. Ah. Thank you. I'm going to look at the pharyngeal walls. I'm going to look at the facial pillars. I want to make sure the uvula is moving. Following this, please take your tongue out. I'm going to wrap the tip of the tongue in gauze, and I'm going to look at the posterior part of the tongue, the base of the tongue, where it meets the floor of the mouth. This is the most likely place for patients to develop cancer. And unfortunately, because of the location, they tend to be diagnosed at very late stages. Thank you very much, and this is the proper way to conduct a head and neck exam. The intraoral, extraoral exam may provide relevant information which you can incorporate into your clinical practice and assist the patient in maintaining optimal health. A few key points to remember. 1. It is essential that the exam is completed for every patient in the same sequence. This will assure that all areas of the oral cavity will be examined. 2. If it is difficult to visualize the inside of the patient's mouth, it may be necessary to have assistance in lighting the field. This is especially true for practitioners seeing patients in a medical, not a dental setting. Additionally, if you're concerned about a lesion or an abnormality in the oral cavity, it is critical that the patient is promptly referred to an oral health provider, preferably one with advanced training in oral soft tissue disease management. Thank you for watching, and I hope this video helps you provide optimal patient care in the future.